This presentation will be covering hypothyroidism, a disorder related to low thyroid levels. This presentation will cover an overview of thyroid physiology, which will touch on the function of the thyroid gland, the purpose of the thyroid hormone, and the actions of the hypothalamic pituitary thyroid axis. Primarily, we will focus on the symptoms and treatment options for hypothyroidism. While this presentation will primarily discuss hypothyroidism, it is important to be aware that it is possible to have hyperthyroidism or too high of a thyroid level. We will briefly talk about this, especially in relationship to oversupplementation of hypothyroidism, but we will not go into too much depth as hyperthyroidism is much more rare and more complex. As you can see in the picture on the right, your thyroid gland is located in your neck surrounding your trachea. The thyroid gland is responsible for producing two different thyroid hormones known as T4 and T3. They are released in a ratio of 5:1, meaning that much more T4 is released than T3. However, T3 is much more potent than T4, approximately 3 to 4 times more potent, and it is the active metabolite. Your body can convert T4 to T3 in the periphery, meaning that after T4 has been released into the bloodstream and taken up by cells in the body, it can be converted to T3. Most of the T3 in the blood is from the conversion of T4 to T3. In addition to releasing the two thyroid hormones, the thyroid gland is also responsible for releasing calcitonin, which is discussed in the osteoporosis module. Thyroid hormones are essential for normal growth and development. They play a role in the body's metabolism, or how the body uses and stores energy. Thyroid hormones are related to the body's temperature and energy levels as well. In addition, the thyroid hormones, iodine is essential for proper function of the thyroid hormones. An iodine deficiency can result in hypothyroidism. The recommended daily allowance for iodine in an adult is 150 micrograms. This RDA increases to 200 micrograms in pregnant women as they need more thyroid hormone to support fetal growth and development, as that is dependent on the maternal T4. Because scientists realized the importance of iodide intake, iodide has been added to most of your salts, like your table salts, to ensure that we do not have iodine deficiencies. So if you look at your table salt at your house, chances are that it will say that the salt has been iodized. The thyroid gland does not work independently in the body. The thyroid is part of the hypothalamic pituitary thyroid axis. This axis is responsible for controlling the release of thyroid hormones and controlling the thyroid levels in the body. So starting at the hypothalamus, which is located in the brain, the hypothalamus releases TRH, or thyroid releasing hormone, which then travels to the pituitary gland, which is also in the brain. This TRH stimulates the pituitary gland to release TSH, which is the thyroid stimulating hormone. This TSH, thyroid stimulating hormone, travels to the thyroid gland, which triggers the thyroid gland to synthesize and release T3 and T4. Then T3 and T4 travel throughout the bloodstream to their targets throughout the body. In addition to traveling throughout the body, the T3 and T4 can travel back to the hypothalamus and the pituitary where all of this started, and they can inhibit the release of TRH and TSH. This is considered a negative feedback loop. So when there are sufficient levels of T3 and T4 in the body, they tell the hypothalamus and the pituitary gland to stop producing thyroid releasing and thyroid stimulating hormone so that no more T3 and T4 are produced, or at least lower levels are produced. When these levels start to drop, then there is less T3 and T4 there to inhibit the release, so the hypothalamus and the pituitary gland start to release the hormones and start the process again. So let's take a second to pause and think about the interaction of the hypothalamus pituitary thyroid axis. Imagine that the hypothalamus is not secreting as much TRH as it normally should. What would happen to the concentrations of TSH, T3, and T4? So if there's not enough TRH, then there would be less TSH. because the thyroid releasing hormone is not telling the pituitary to release the thyroid stimulating hormone. So if there's less TSH, then there would be less T3 and T4 because the TSH is not telling the thyroid to release T3 and T4. So the concentrations of all three hormones in this situation would decrease. This would be a very rare case, but it helps us think about the interplay between the hormone levels. Now that we've talked about how the thyroid hormone control should normally function, we are going to switch gears and talk about a common disorder of the thyroid gland. Hypothyroidism is a deficiency of the thyroid hormone that results in low thyroid levels. It is usually related to an autoimmune disorder affecting the thyroid gland. It is fairly common and it's seen in 3.7% of the U.S. population. The likelihood of getting hypothyroidism increases with age. It is seen more commonly in women than in men. Hypothyroidism is diagnosed by high levels of TSH and low levels of T4. Remember that negative feedback loop between TSH and T4, so the levels are inverse to each other. High TSH usually means low T4, and high T4 usually means low TSH. This will come in handy when we think about dosing and monitoring patients. The opposite of hypothyroidism is hyperthyroidism, or too high of thyroid levels. This is more rare and only seen in 0.5% of the U.S. population. It is commonly caused by Graves' disease, which is an antibody produced that acts on the TSH receptor site on the thyroid, which stimulates the thyroid gland to produce too much T3 and T4. We won't be discussing the treatment of hyperthyroidism in this presentation, but it is helpful to know that it is possible to have hyperthyroidism. This slide compares the symptoms of hypothyroidism and hyperthyroidism. You will see some common symptoms on both sides, such as fatigue, irregular menstruation, and goiter, which is a lump or a growth in the neck. However, there are several differences between the other symptoms. Hypothyroidism you can think of as slow and low metabolism. So you're thinking about things like weight gain, fatigue from a low metabolism, intolerance to cold or always feeling cold, constipation, and bradycardia or a slow heart rate. So all of those things are kind of the body slowing down. On the other side, hyperthyroidism can be thought of as an increase in basal metabolic rate. So you have fatigue but from an overworking metabolism, you have a heat intolerance, increased bowel movement, nervousness, anxiety, and tachycardia, or a fast heart rate. Let's take a look at a patient example of symptoms to think about if it's hypothyroid or hyperthyroidism. So a patient comes into clinic complaining of fatigue. She complains of always being cold, gaining weight, and is afraid she's losing some hair. Her heart rate is slower than would be expected. She has a small goiter, and her health professional decides to check her thyroid function. Would you expect her TSH and T4 levels to be normal? If not, what would you expect? We're going to take a second to pause on this slide, and then we'll talk about the answers on the next slide. Okay, so she has fatigue and a goiter, but that could be either hypo or hyperthyroid, so that doesn't help us much. But the other symptoms of always being cold, gaining weight, losing hair, and a slow heart rate, that all points to a low thyroid or hypothyroid state. So what does that mean about her TSH and her T4? Well, the low thyroid would mean that there's low T4, and since they have an inverse relationship, you'd expect to see a high TSH. Then how would we treat this patient with low thyroid? The most common treatment is a synthetic version of thyroid hormone, or synthroid. So if you think about it, synthetic, thyroid. This just contains a synthetic version of T4, and then your body can convert it to T3. It works to replace and supplement your body's natural thyroid hormone. This is usually the first-line therapy and the treatment of choice for hypothyroidism, but it is helpful to know that there are other options on the market. Another example is a medication called Armour Thyroid, and this is made from thyroid hormone of pigs and contains both T3 and T4. For some patients, they are able to get better control with the combination of both T3 and T4. Treating thyroid deficiency often takes a lot of trial and error to get the levels just right. Because levothyroxine, the synthetic version, is much more common and preferred, we will be focusing on that for the remainder of this presentation. The adverse reactions of levothyroxine are rare as long as the patient is not over-supplemented. If a patient is given too high of a dose for a long time, it may increase the risk of bone loss, as being in a hyperthyroid state increases your risk of bone loss. Additionally, while the synthetic version has a low risk for allergic reaction, this risk was much higher with the animal versions because it contained actual animal thyroid hormones. There are some disease states where you need to be more cautious with thyroid supplementation, such as uncontrolled cardiovascular disease, other hormone imbalances, and people trying to use excess hormone supplementation for weight loss. This is not allowed or safe to do. Like I said earlier, there's often a lot of trial and error in getting the right dose of thyroid hormone. The dose is very individualized, and there are many doses available on the market. For many medications, there may only be a few different dosing options, but levothyroxine has 12 different dosages to provide a lot of options to patients. To track the efficacy of the thyroid supplementation levels of TSH and T4, those are usually drawn every 6 to 8 weeks until stabilized, and then annually, but they may be drawn more frequently if the patient experiences some of the symptoms that we talked about with high or low thyroid. And so remember, in the inverse relationship of TSH and T4, so when the levels are drawn, if TSH is high and T4 is low, then this means that the dose is too low and that more levothyroxine should be given. If the level comes back that the TSH is low and the T4 is high, this generally means that the dose is too high. If the patient becomes pregnant, they will need to be monitored more closely, as they will often require higher doses to support that fetal development. Additionally, as patients are started on new medications that may interact with levothyroxine or with their metabolism, they may need more monitoring and dose adjustments. There can be severe complications if hypothyroidism is not treated. An interesting one is carpal tunnel, which sometimes can improve when hypothyroidism is treated. Additionally, there are complications for women such as preterm birth or low birth weight. There are also interactions between drug and disease effects for patients with hypothyroidism. So if you remember from the cardiovascular lecture and clot lecture, we talked about warfarin being used as an anticoagulant. Patients who are in a hypothyroid state typically require lower doses of warfarin, and patients who are in a hyperthyroid state may require higher doses. Patients who are in insulin may need lower doses of insulin if they are hypothyroid. Patients who are on opioids and are hypothyroid will be more sensitive to the respiratory depression, and opioids should be used cautiously in these patients. Additionally, there are drug interactions such as calcium or aluminum hydroxide, which is often found in over-the-counter antacids, or iron, which can bind the levothyroxine and make it much less effective. Let's take a second to think about potential interactions. So if a patient takes his levothyroxine every day in the morning before breakfast, he then decides that he should be taking a multivitamin with iron and calcium supplement every day for his general health. Are there any drug interactions here? Thinking about what might be in a multivitamin, it likely has iron, calcium, and it may have some aluminum. All of these are responsible for binding to levothyroxine and making it much less effective. So he should take his vitamin later in the day, preferably at least 4 hours later. So you may encourage him to take his supplements with lunch or dinner. When a patient picks up a prescription for levothyroxine, we often counsel on the importance of taking it on an empty stomach before breakfast or any other medications. So if he was taking his vitamin at the same time as his levothyroxine, what would we expect to happen to his TSH levels? So his T4 levels would decrease because he isn't getting the full supplementation for the dose, so the T4 would not be providing that negative feedback level, so there would be high TSH. So to summarize, the thyroid gland is responsible for producing thyroid hormones, which are controlled by a negative feedback loop. Thyroid hormones are essential for regulating the body's metabolism. Thyroid gland disorders can be caused by a deficiency or excess of thyroid hormone, and a deficiency of hormone is much more common. The symptoms of hypo and hyperthyroid are often opposites, and the treatment for hypothyroidism is to supplement giving thyroid hormone.